Hi, I'm Aaron Savage from Albury Station, and today I'll be presenting a rather rare pre-hospital presentation on Kounis syndrome, precipitating Takotsubo syndrome. The patient was a 73-year-old female living at home with her husband, has independent ADLs, past medical history of right coronary artery stenosis, generalised back pain, and a large BMI. She had no documented allergies and takes regular Panadeine Forte and aspirin. The patient's condition began after consuming a normal meat and vegetable meal prepared at home, with ingesting an off-brand coffee vanilla rum liqueur, which was her second time exposed to it. 15 minutes later, she developed signs and symptoms associated with an allergic reaction consisting of full-body urticaria, 3 large vomits, a large episode of diarrhea, and she self-administered 25 milligrams of Phenergan. 30 minutes post the allergic reaction, she developed right-sided chest pain, described as sharp, radiating into her back. She developed severe diaphoresis and breathlessness. Urticaria at this stage began to resolve, however, nausea persisted. On our arrival, she remained significantly diaphoretic, presented with an increased respiratory rate, with full field air entry, nil adventitious sounds. She was borderline tachycardic and hypertensive with a blood pressure of 85/65. Her pain was a 5 out of 10. Secondary survey revealed resolved urticaria, ischemic-like chest pain, restlessness, however, an adequate perfusion assessment with cap refill less than 3 seconds to all her extremities. 4 separate ECGs were conducted. The first was not diagnostic quality. The second and third indicated an acute anterior infarct with notable elevation in V3 and V4. Her QTC was 442 milliseconds. Whilst on scene, her blood pressure began to move to the normotensive region, and this was without intervention or change in posture, and her 5 out of 10 pain subsided to 1 out of 10 without any management. This case took me by surprise. I was met with several differential diagnoses, and gaining a thorough history was paramount. It was acceptable to call an allergy as the primary and acute coronary syndrome as the secondary. Regarding anaphylaxis, it was a very thorough assessment was conducted to determine if an appropriate to treat with multiple doses of adrenaline and large volumes of compound sodium lactate. However, per New South Wales ambulance protocols, the patient did not have any of the following signs of anaphylaxis. We didn't discount this as a differential, and we kept it at the forefront of our treatment in case presentation changed. In regards to cardiogenic shock, the patient had intermittent chest pain, ST elevation and hypotension, however, was currently perfusing very well. Again, this differential was also kept at the forefront of our treatment. The patient was technically meeting sepsis criteria, however, had no source of infection through history taking, and events post-consumption of the alcohol linked us to the antigen problem instead. Relative fluid loss from the diarrhea and vomiting was also considered. Our management on scene treated both the allergy and the acute coronary syndrome. She was administered 180 milligrams of fexofenadine, 300 milligrams of aspirin. GTN was withheld because it was contraindicated. 20 gauge was inserted into the wrist. 4 milligrams administered intravenously of ondansetron. Patient declined IV pain relief and opted to take her own Panadeine Forte instead. We consulted with the cardiologist with the 2 STEMIs and discussed with the background history, the medical history, and the absence of reciprocal changes. The intermittent ST elevation was noted, and both parties agreed that the patient was presenting as a STEMIc mimic. After departing at 11 p.m, her blood pressure en route continued to normalise. However, she was still presenting with intermittent tachycardia. Her pain completely resolved en route to hospital. Unfortunately, the patient was unable to be offloaded to the hospital bed for 5 hours and remained with us on stretcher. Shortly after triage, her work of breathing increased with full field expiratory wheeze. At this stage, her pain began to reoccur. Over the 5 hours, our management included a single dose of salbutamol, 3 2.5 milligram aliquots of IV morphine per the ED doctor's request, and high dose of 900 milligram of aspirin. Serial bloods were taken, indicating troponin rise of 3,400, which repeated rising to just over 5,000 at the 5-hour mark. Multiple ECGs were conducted over the 5 hours, all showing different diagnoses, including an anterior septal elevation, potential pericarditis with runs of ventricular ectopic beats, and consistently higher heart rate changing between 90 and 120. Throughout the night, her pain would come in waves and self-resolve, with her blood pressure beginning to subside. Nitrates were withheld for this reason. This ECG was one of many taken throughout the night, notably showing minimal elevation in several leads, including anterior septal. There's Q waves present, and at one stage, PR elevation in AVR. Her QTC continued to prolong to 491 milliseconds. An interim diagnosis was made of pericarditis. The patient was admitted and remained in hospital for 7 days. Her CTPA was negative. However, an angio and echo found the following: right coronary artery stenosis at 30%, left ventricular and diastolic pressure of 25 millimeters of mercury. Her left ventricle showed severe systolic dysfunction with apical hypokinesis. Her ejection fractions were 20%. It was at this point she was diagnosed with Takotsubo syndrome. Pericarditis was ruled out. This leads us to the condition she experienced and was diagnosed with: Kounis syndrome, also known as allergic angina, that precipitated Takotsubo syndrome. Kounis syndrome is significantly undiagnosed in pre-hospital and emergency healthcare despite its prevalence. It's a condition where acute coronary syndrome events are precipitated by an allergic or hypersensitivity reaction through mast cell activation. Histamine release, tryptase, chymase, leukotrienes, cytokines, all these drive endothelial dysfunction, coronary vasospasm, and in some patients, plaque erosion. Documented acute coronary syndromes include chest pain, diaphoresis, dyspnea, overlapping with allergic features, including skin or respiratory symptoms, up to 60 minutes post-exposure to the antigen. Her ECG changes may be transient with ST elevation appearing or disappearing. Troponin levels can be normal or elevated depending upon the phenotype of the Kounis syndrome. So there are 3 types of phenotypes. Type 1 being the most prevalent, where vasospasm presents with an underlying normal or near normal coronary arteries. Troponin may or may not be elevated. Type 2 is less common, presents with vasospasm with underlying pre-existing atheroma, which may or may not present with plaque erosion and myocardial infarction. Troponins are elevated. The patient fits this phenotype with confirmation of the angio echo showing 30% stenosis of the right coronary artery. Type 3 is the least common and is caused by stent thrombosis or restenosis due to an allergic inflammation. A large study was conducted in the United States and found Kounis syndrome occurs in 1.1% of patients with an allergic reaction and has a relatively high mortality rate of 7%. Complications associated with these conditions are cardiogenic shock, arrest, or death. So how does it happen? Specifically, an IgE-mediated response links to high affinity receptor sites that activate mast cells within the myocardium and coronary vasculature. These mediators then constrict arteries, destabilize plaques, and modify platelet function and thrombosis. Specifically for my patient, histamines provoke vasoconstriction, reduced end diastolic pressure, leukotrienes are patent vasoconstrictors, and chymase can augment angiotensin II, reinforcing vasospasm. Moving on to the findings from the echo and the angio, the patient was diagnosed with Takotsubo syndrome. It predominantly affects older women and is triggered by an acute stressor. However, mechanistic hypotheses have been studied. It's defined as transient left ventricular systolic function, classically featuring basal hypokinesis with apical hypokinesis, ST elevation, and minimal obstructive coronary disease. The patient did not exhibit severe emotional distress prior to events. However, the surge in catecholamines and stress peptides, microvascular dysfunction, and multivessel epicardial spasms were present. Allergic reactions can precipitate the condition, connecting Kounis syndrome to Takotsubo syndrome. The two conditions together are extremely rare and study cohorts are limited. Approximately 1.1% of hospitalized allergic hypersensitivity or anaphylactic conditions are diagnosed with Kounis syndrome, And of the diagnosed, approximately 1.5% develop Takotsubo syndrome, which equates to 0.017% of all allergic anaphylactic presentations. Evidence coming out now with the two conditions combined is increasingly supported. These patients present with mediator-driven endothelial injury, epicardial microvascular spasms, sympathetic activation, and excessive catecholamines. So the treatment and evidence for the pre-hospital setting for us, medication regime should focus on treating the allergy concurrent to ACS. This includes vasodilators where blood pressure allows, avoidance of morphine and codeine, and opting for fentanyl instead. Unfortunately for this patient, she self-administered codeine on scene and per the doctor's request was administered morphine and ED. This would account for the continuation of transient ST elevation and blood pressure drop. Alternative analgesia that does not induce further mast cell degranulation is supported as best practice. Oral paracetamol and Kounis syndrome research is unknown. However, intravenous paracetamol has been associated with hypertension. Moving forward with patients presenting with Kounis syndrome, acknowledging this would sharpen clinical practice. Steroid-mediated correction of isoionophilia and Kounis syndrome and Takotsubo syndrome has been reported in studies. Hydrocortisone specifically was not mentioned as the steroid. However, a 2022 study of Kounis syndrome in an emergency department recommended that type 1 was managed with hydrocortisone 5 milligrams per kilo per day. VCCC consultation or VCP for hydrocortisone in these patients is evidence-backed for improved outcome in both Kounis syndrome and Takotsubo cardiomyopathy, or albeit both conditions at the same time. It should be considered without presence of anaphylaxis. Regarding dosage, sticking with the current New South Wales ambulance pharmacology of 100 milligrams for adults could be acceptable. However, further research needs to be determined on that correct dose. So considerations for pre-hospital or emergency health practice is important in developing guidelines in the treatment for this undiagnosed condition, consisting of a relatively high mortality rate. Regular ECG should be taken to assist in developing a clinical picture to determine if the Kounis syndrome is solely vasospasm or vasospasm and late-stage stenosis causing occlusion. Adrenaline remains the life-saving treatment for anaphylaxis, but it can aggravate coronary spasm and potentially trigger or exacerbate Takotsubo syndrome. If essential, sulfite-free formulations are preferred. Monitoring relative circulatory loss should be managed appropriately, and caution should be taken in Takotsubo patients. Treatment for either cardiogenic shock or anaphylaxis should be thoroughly investigated and continually monitored. Ensuring that all pathways are explored is essential in practice. Underdiagnosed or misdiagnosing these complex presentations require a thorough history taking and understanding of the pathophysiology and pharmacology. The patient was eventually discharged at 7 days with a fluid restriction of 1.2 litres and daily Lasix. So thank you for your time. This is the complete list of references used in this presentation.